Hi there, everyone. Thank you so much for tuning in. For those of you who may not be familiar with me, my name is Kayla Smock, and I am the president and founder of the Occipital Neuralgia Foundation. Today, I have the privilege of speaking with Dr. Ziv Peled. Dr. Peled is a Harvard-trained plastic and peripheral nerve surgeon who has a special interest in chronic headaches, which of course includes occipital neuralgia. So Dr. Peled is coming to us today with a wealth of knowledge, being that he also serves as president of the Migraine Surgery Society. So Dr. Peled, thank you again for being here with us today. I'm really excited for this conversation. Why don't you give us a brief introduction?
Yeah, thank you so much for having me, Kayla. It really is a privilege and an honor to be able to share the things that I know about headache surgery, which is a huge focus of me in my practice and has been for well over a decade now. So, by way of background, I am a plastic surgeon, board certified plastic surgeon, finished up in Boston, as you know, and then I actually did a peripheral nerve fellowship, focusing on lots of different kinds of peripheral nerve problems. For example, carpal tunnel is one that people are probably most familiar with, but you have tarsal tunnel, similar kinds of nerve compression issues in the lower extremity and the groin. And as we'll talk a lot about, hopefully over the next few minutes, a lot of times in the head and neck, similar problems. And so
Mm-hmm.
when I first did my peripheral nerve fellowship, uh, there was only a few papers out there, and people were just beginning to talk about headache surgery or surgery for occipital neuralgia as a
Okay.
possibility for something that could be done. And what I realized very quickly, to the point about compression, is that a lot of times the compression that we see in other parts of the body, for example, the carpal tunnel, was occurring in the head and neck. And I already knew
Mm-hmm.
that it wasn't just the arms and legs that happened, but it occurred in the trunk. And now we realized it was happening in the head and neck. And that kind of opened the doors for me. And it's been a great ride ever since.
Sure.
Yeah.
That's great. And for those of you who may have missed, Dr. Pellet and I spoke a couple of years back. So if you missed that interview, definitely go check it out. We spoke about everything occipital neuralgia related, from symptoms to diagnosis to treatments. So that is available on our YouTube channel, and then also on our website, which is onfsupport.org. But that kind of brings me into my next point here. So as we know, healthcare is always evolving. There are always new advancements in medicine, right? So today we would kind of like to dive a little bit deeper and grasp a better understanding of how these changes have been specific to occipital neuralgia and headache surgery. So I understand that you have a recent publication in the Journal of Plastic, Aesthetic, and Reconstructive Surgery, right?
Yep. Yep. Exactly right.
Great. Okay. So I think that publication will kind of serve as the premise for most of our discussion today.
Hmm.
So for our viewers, if you would like to follow along, it is an open access publication. It is called Introduction to VSI Migraine Surgery, again in the JPRAS Open. And the authors were, of course, yourself, Dr. Pellet, and then also Dr. Lisa Frere.
Hmm.
So would you, I understand also that you have kind of been involved in headache surgery since its like rediscovery, let's say, right? So
Yeah.
would you mind explaining a little bit more about maybe what headache surgery looked like when you first became involved in medicine?
Right. So, great questions. And I think what's interesting about headache surgery and what I titled this article, at least the beginning, is moving forward but looking back. Um,
Mm-hmm.
Headache surgery as we know it today, and the variations of it that those of us that continue to do a lot of it practice, was reintroduced in 2000 by a really brilliant gentleman by the name of Bauman Guyron, also a plastic surgeon, very famous aesthetic surgeon. But
Mm-hmm.
before going to what he really discovered, I think it's important to realize, when I say rediscovered, the concepts here actually date back to 936 AD, when a guy named
Wow.
Al-Zahrawi uh, actually first described the idea of cauterizing or burning certain nerves in the head and neck to treat chronic headaches. So this is a concept that has been around for a very, very, very long time. He actually codified this entire process in a book, and I'm sure I'll mispronounce this, but I think it's called the Khitab al Tasrif.
Okay.
And again, before the turn of that first millennia, he was doing this kind of work. And then a few centuries later, there was another gentleman by the name of Ambrose Paré who lived from 1510 to 1590. And he would talk about the gentle art of surgery and is one of the first practitioners that actually spoke about focusing on how the patient went through the surgical process and the idea of trying to minimize pain, designing instruments specifically for the type of surgery that he was planning to do, one of which was tying off blood vessels that were injuring nerves in the head and neck. And
Okay.
so, again, these concepts have been around for many, many, many years. But in 2000, Bauman Guyron actually made a really amazing observation. To his credit, he's not just someone who continues to do surgery and crank out cases, but he was a very, very famous and continues to be a very, very famous aesthetic surgeon. He was doing a lot of endoscopic brow lifts. So, for those in
Okay.
the audience who don't know, you make little incisions kind of behind the hairlines, and with a camera, you go dissect down to kind of the brow region and you lift up the eyebrows to create a more youthful appearance. Part of that operation involves oftentimes cutting little nerves here in the front of the temple called the zygomaticotemporal nerves. And to release the muscles here that cause these 11s that I have when I scowl at the camera here, that we were often treating with Botox. And you release a lot of that musculature that allows you to elevate the soft tissue of the brow and give you that more youthful look. What he
Okay.
realized after hundreds and hundreds and hundreds of these operations is that significant subset of his patients would come back and say, really love how I look. That's great. But just so you know, I used to also have these really bad headaches, and
Mhm.
either they're gone or they are so much better. It's been a remarkable added benefit. And to his credit, and he was, as I recall, in private practice at the time, he began to study this in a very formal way. And
Mhm.
back in 2000, actually did a retrospective study where he went back and looked at several hundred of these cases. And what he found was that of the people that he had operated on who had chronic headaches and had been diagnosed with migraines by their neurologists, because all of these people were seeing neurologists to try and treat their headaches
Mhm.
and were not getting enough relief, a
Mhm.
significant number of them, even 4.5 years out at the time he did the study, we're still reporting a significant reduction in the frequency, severity, and or usually and duration of their symptoms. And so
Wow.
about a year later, he actually did a prospective study where he said, look, I'm going to actually look at patients who come to my office who have headaches. And when they have the really hyperdynamic brow that I have, meaning the muscles here are very strong, you can see these deep 11s, as we call them, he would
Mhm.
treat them with Botox and try and relax those muscles. And if they got good relief of their headaches for a few months, because Botox, as many of us know, isn't a permanent fix. It's something that you have to keep
Mhm.
doing every few months. But if they got good relief with Botox, he would actually operate on them, not for any aesthetic reasons, but simply to release these nerves. And
Mhm.
again, found that in that small prospective study, 21 out of 22 patients, again, were in the success category, which we now pretty routinely define as a minimum 50% reduction in frequency, severity, and or duration of symptoms. And then when we realized, okay, there's nerves here in the forehead and perhaps the front of the temple that are causing headaches, people began to look at, well, are there other areas in the head and neck where people are experiencing similar types of symptoms?
Mhm.
Of course, there are a lot of people with temporal headaches where they feel like there's a vice-like sharp shooting
Mhm.
pain that's pouring through, and certainly as is the focus of your organization, which is amazing, by the way. So
Thank
kudos
you.
to you for creating it and continuing to allow it to flourish. In the occipital region, which just means the back of the head, and
Right.
Yvonne Ducic, who was a professor, I think is an associate professor of plastic surgery at Georgetown at the time, did some of the earlier studies. And the upshot is that much like compression or pressure on a nerve at the wrist, if you have carpal tunnel syndrome, we realized that there were pressure points that a lot of these nerves experienced throughout the head and neck, and that if you release
Mhm.
those, you could actually get really good benefits. And that really kind of got the ball rolling, I believe, in the first decade of headache surgery, which in my article I sort of say is anywhere from 2000, which was the first paper by Bob and Guy around talking about, can you do this, and how do you diagnose it, and how do you decide who and where to operate on.
Mhm.
And so that first decade was really focused on trying to kind of figure out the lay of the land, sort of people, you know, moving from the colonies in the east coast of the United States
Mhm.
out west. You're trying to see where the landscape was and how far you could
Mhm.
go, and what made sense.
Wow.
Yeah.
That's like an incredible backstory to like the surgery that we know of today.
Yeah.
So when we're talking about headache surgery, migraine surgery, nerve
Mhm.
decompression surgery, are those terms kind of used interchangeably?
Yeah, so
Okay.
I have a personal feeling about this. It's not shared by every single one of my colleagues, but I think
Mhm.
the term migraine surgery really came about because so many of the people that would show up to our offices had been diagnosed with chronic migraines, and
Yes.
I think that there are certainly patients who have nerve compression who have headaches that share migraine like characteristics. But
Mhm.
the way I like to think about it is that generally speaking, a true migraine, irrespective of the symptoms, but in terms of the underlying cause, is really a chemical abnormality. And there
Right.
can be a lot of components to that. It's certainly a very complex neurological disorder, and I'm talking about migraines now.
Mhm.
So it's not one thing that can cause these symptoms, but there are lots of very reasonable theories that have a lot of data behind them. So, for example, there is a whole class of drugs that any migraine patient is likely to be familiar with called the triptans, sumatriptan or
Mhm.
Imitrex, elatriptan, frobatriptan,
Mhm.
rizatriptan. There's a whole gaggle of these drugs, and I believe that they had their heyday, so to speak, in the late 80s, 90s.
Mhm.
And their whole idea is to modulate or vary the levels of serotonin, which is a chemical that is released in the brain
Mhm.
that is thought to play a role in the generation of headaches. Um, we have since moved on with the newer generation of calcitonin gene related peptide receptor. It's a mouthful, but a
Mhm.
different chemical called calcitonin gene related peptide that is also involved in headaches. And so the newest class of drugs are like the Imavig, Emgality, Ajovy, Ubrelvy, and I believe it was 2017 that the FDA first approved the first of these, which is Imavig. Um,
Mhm.
but at its core, migraines are a chemical abnormality. And so, if you are
Mhm.
like my wife's best friend who's had a diagnosis of migraine for years, and you find the right chemical agent or right medicine to modulate whatever the issue happens to be in your case, your symptoms are very manageable. So she takes, I believe it's one nortriptyline a day, has a very low
Mhm.
dose, doesn't have any side effects, and essentially has no residual symptoms except for a very occasional bad day. And
Mhm.
so when patients first presented to offices like Dr. Guyron's and Dr. Duchik's in the early days of the surgery, many of them were diagnosed with migraines, and then they had failed all of the medications and all
Mhm.
of the injections that you use to try and reduce inflammation, et cetera, et cetera. It's a lot of steroid injections that many of our patients have undergone. And so when we did the surgery that would help them, it took on the moniker, sorry, of migraine surgery. But at
Okay.
its core, the idea that we're treating is neuralgia, meaning nerve pain. The question is always which nerve is causing the algia. And then if you can
Mhm.
figure that out, can you do anything about it? And what we were
Mhm.
essentially doing is, in many cases, decompressing, meaning
Mhm.
taking the pressure off of the nerves in these cases. So, for example, in occipital neuralgia, there are three named occipital nerves: the greater, the lesser, and the third, which is also known as the least occipital nerves. Those are the three main targets. And when you look at the lesser occipital nerve, for example, in a paper I published many years ago now, I think it was 2014, There are three compression zones for that nerve as it comes out behind this muscle here that you can see in my neck called the sternocleidomastoid, as the nerve
Hmm.
ascends along the back end of that, and then as it crosses what's called the nuchal line, where all of these muscles insert into the base of the skull in the back. And
Okay.
so when you were able to do surgery on patients, you would look at those compression zones or points and
Hmm.
decompress, take the pressure off the nerve in those areas. And what was causing the compression? Sometimes it was just a spastic muscle that had a nerve passing through it. The muscle was really squeezing it tightly. And so if you were to remove a little bit of that muscle, the rest of the muscle can function well. But this muscle fiber here that was squeezing that nerve is now no longer there. And so the muscle would still
Okay.
function, but the nerve didn't have any pressure on it. Sometimes it was enlarged blood vessels. Sometimes it was blood vessels wrapping around the nerve like an anaconda. Sometimes there were chronically enlarged lymph nodes, which is something that we might get into a little further, something we've seen a lot more recently since 2020 with the onset of COVID. And I have a lot of
Mm.
ideas as to why that is the case.
Okay.
Um, but to answer your question in a very roundabout way,
Hmm.
migraine surgery really is neuralgia surgery, which is nerve decompression surgery in the vast majority of cases, because that's actually what you're doing.
Got it. Okay. Yeah, I mean, even through like some of my research throughout the years, I was getting confused myself when I was reading migraine surgery versus nerve decompression surgery. So that was a great explanation. So thank you for that. So going back to what you had just mentioned about like maybe like the different muscles, like even in the neck that are like compressing the actual nerves, and that is kind of what nerve decompression surgery is meant to target.
Hmm.
I understand that there was a recent publication again by Dr. Lisa Frere,
Hmm.
and she found that I believe it was the trapezius fascia. It
Hmm.
was 3 millimeters thick in the vast majority of these occipital neuralgia patients, which,
Yeah.
correct me if I'm wrong, but it's almost three times the width of a healthy patient. Is that right?
Yeah, so it was a really great paper for a number of reasons. And Lisa's a phenomenal researcher and a world famous headache surgeon already in her own right. She's going to be where I
Hmm.
am in a very short period of time, is much younger than I am. So it's certainly way ahead of where I was at her stage of the game. So I can't say
Hmm.
enough great about Lisa. But yeah, in that paper, what they were able to show was that in patients who had unilateral symptoms, meaning let's say symptoms only on the right side of the back of the head, when they
Okay.
looked at, so first of all, let's define what fascia is. I think of fascia
Hmm.
and I describe fascia to the patients as kind of like if you're ever preparing a breast of chicken and sometimes you have that really kind of thick sinew over the chicken,
Yes.
it's really chewy, you don't really like to eat. So you take a nice fillet knife and you clean that off.
Hmm.
So on the covering of human muscle, you have this very thick fibrous tissue called fascia. The other way to think about it is sort of like one of those Tyvek or fiber envelopes, those really tough fiber envelopes that you
Hmm.
just can't tear. You can put a 50-pound brick in there and shake it, and it still doesn't have any holes in it, as opposed to, for
Right.
example, a brown paper bag where the brick would fall through that in like a second. So that stuff is really thick, and it's the covering of all the muscles on the superficial and the deep surface. What they found when they went to operate on these people is that on the affected side, so if you had right sided symptoms, when they decompressed that nerve, they would look at the fascia and it was many times thicker on the
Hmm.
affected side as compared to the unaffected side, where they would also kind of be looking because that's how you had to open up the incision.
Hmm.
And so the idea was that, again, we continue to learn more and more. It's sometimes not just the muscle, sometimes it's just how the fascia developed on that side, for example, in patients who have unilateral symptoms,
Hmm.
where the fascia was so thick that the nerves were passing through these little tunnels, but they were squeezed so tightly that every time the neck moved, that nerve would get kinked as opposed to being able to glide very smoothly because that fascia
Okay.
was so tough and so thick. So yeah, there's
Okay.
another something we'd suspected for a long time, but that they looked at very
Hmm.
formally and scientifically and showed was the case.
Right. And I think in your paper also there was a mention of thoracic outlet
Hmm.
syndrome
Yeah.
being in, oh, I think it was 70% of occipital neuralgia cases. So is that kind of a similar idea?
So, the concept with thoracic outlet syndrome is a little different. So,
Okay.
thoracic outlet syndrome, again, is a really terrible wording, but it refers to compression of nerves that come out of the neck and head
Mhm.
typically down to the upper extremity, meaning the arm, the forearm, the hand, even
Mhm.
the shoulder, and sometimes even the upper back. There's a whole nest of nerves, which is every first year medical student's worst nightmare, called the brachial plexus. It's this really complex on and off ramp of nerves connecting back and forth. And those nerves are compressed here, usually with all the muscles in the neck. And
Mhm.
when those nerves kind of get compressed, they cause symptoms usually in the upper extremity. Now, one of
Okay.
the things that's interesting, and that has this work has really been pioneered by another colleague and really good friend, Robert Hagen in St. Louis. Uh, there is a It used to be just the term thoracic outlet syndrome, meaning compression of the nerves, but it used to be thought that the compression was these big, large blood vessels here just under the neck,
Okay.
and also a very unusual location of the first rib, which you can't even really see or feel in most people. It's kind of under the collarbone. And so for years, people were doing operations to remove the first rib and to kind of tie off or reposition blood vessels in certain areas. And they met with some success, but we now realize that there are two different kinds of thoracic outlet syndrome. There is what should be treated by first rib removal and
Mhm.
management of blood vessels, which is vasculogenic thoracic outlet syndrome. Again, the genesis is an issue of vascular or blood vessel compression of these nerves. And then there is what he now appropriately terms neurogenic thoracic outlet syndrome. In other words, the blood vessels are fine. Blood vessels aren't doing anything
Okay.
bad. The first rib, totally normal, just like it is perhaps on the other side. But the
Mhm.
problem really is the muscles here, just like the muscles in the back of the neck, compressing these nerves. And so
Okay.
there's a lot of redundancy in these muscles. And so you can remove little bits of these muscles to, again, decompress the nerves
Mhm.
and relieve a lot of the symptoms. The question you were asking, and I think this is the point you were getting at, is that fully 70% of patients who actually have neurogenic thoracic outlet syndrome can have symptoms that are similar to occipital neuralgia. And so,
Got
if
it.
you're presenting to the office and you have a lot of symptoms that are more classically occipital neuralgia, one of the
Okay.
questions that should often be asked is like, hey, are you getting a lot of upper extremity symptoms? You have shoulder pain. And I don't mean like tightness, like you actually get any sharp shooting pains. You get numbness, tingling, zinging in the hands and the forearms. And
Mhm.
typically, not always, but typically, thoracic outlet syndrome is unilateral, it's not bilateral. There are
Okay.
also a few other symptoms that, in my experience, you don't typically see with neurogenic thoracic outlet
Mhm.
syndrome, such as that hyperesthesia or tingling, kind of like the my hair hurts type of
Okay.
symptomatology. It's really a little bit different. So um, I think that's one of the sort of hallmarks of the second decade of
Mhm.
research into headache surgery, which is, I think, a more general term because these people have
Mhm.
headaches, whether there's migraines and neuralgia, just migraines, just neuralgia. Um,
Mhm.
but one of the hallmarks of our ability to continue to move the field forward is to recognize that there are other syndromes that can mimic occipital neuralgia, and
Mhm.
thoracic outlet, specifically neurogenic thoracic outlet syndrome, is one of them.
Right. Okay. That's really interesting. Wow. So like you had mentioned, you've been in the field for quite some time now. How have you noticed a shift in like these headache surgeries and these like surgeries for neuralgia pain?
Yeah. So I think there's been a lot of changes over the years, and it continues to improve, which is really again a hallmark of a field that continues to look at itself critically and move forward. And I think that's only better for patients.
Mm-hmm.
As I said in that one paper, which I encourage people to read, hopefully it makes sense, as I don't think it's too technical. The first
Mm-hmm.
decade was really trying to kind of figure out the landscape. Where are these
Right.
nerves located? What are the nerves? And what is the anatomy of the nerves as they are passing through these tissues? So, in the frontal region, we have the supratrochlear nerves, which are just kind of on either side of the base of the nose. We have the supraorbital nerves. And we have in the temple, the zygomaticotemporal and auriculotemporal nerves. And in the back of the head,
Mm-hmm.
like I said, we have the greater, the lesser, and the third occipital nerves. And in
Mm-hmm.
addition to sort of naming the nerves, what we became really good at identifying is where are all the potential compression points for those nerves. So, for example, the greater occipital nerve is well established to have 6 potential compression points as it passes through all the soft tissues of the neck. And you have to look at all 6 of those points each time you operate. Not
Mm-hmm.
not every single one of those points will be a true compression point in every patient. So,
Mm-hmm.
what I say to my patients before surgery is I'm going to look at every single one of those points. And if point one looks good, I'm going to leave it alone. If point two looks good, I'm going to leave it alone. If point three looks like there's a compression of the nerve there, I'm going to release that. Same thing with points
Mm-hmm.
4, 5, and 6. So, in
Mm-hmm.
addition to identifying the nerves, we became, in a very methodical way, able to identify where all those potential compression points were and
Okay.
sort of codifying how to release all of those points to get a complete release. And I think that in the first decade of surgery, we realized not only that we were able to identify these and
Mm-hmm.
identify the compression points, but also continue to follow the patients and see that, generally speaking, the surgery worked really well. In the second
Okay.
generation, or the second decade of headache surgery, which I think is 2011 to 2020, we also realized that there were other potential compression points
Mm-hmm.
in these areas that we continued to realize were a problem. So, for example, it was first thought that understanding the anatomy, the problem in the nerves here, the supraorbital and the supratrochlear, was as the nerves pass through the muscles. And so the focus was on really releasing the muscles here to
Okay.
create a nice path for those nerves to glide. What became apparent after a few more years is that a lot of times these nerves were really getting pinched just as they passed through the eye socket. So, for example, when you look at the anatomy in a lot of textbooks, the supraorbital nerve will come out of the back of the eye, and then as the nerve passes over the top of the eye socket, it will come out and head up just on the underside of all this forehead tissue to provide the sensation to that side of the forehead. And the idea was the classic anatomy is such that you have this bone here, and then there's like a little notch and then
Okay.
a continuation of the bone. So the nerve had a little corridor through which to come through. But a significant number of these patients, the notch, the space that the nerve was going through was incredibly tight. There was a lot of very thick fascia, and it's not
Mm-hmm.
called fascia when it's covering the bone, it's called periosteum, but the tissue
Okay.
quality is essentially identical. It's just that that's what we call it when it covers the bone. And so the nerves were being compressed at the orbital rim. Sometimes there were blood vessels next to the nerves that, in a very
Mm-hmm.
fixed space, were actually banging against the nerve. So you had this blood vessel that was punching the nerve, and because the nerve was in a tight space, it had nowhere to
Okay.
go. And so you had this artery that was constantly pounding at it. That's why a lot of patients would then kind of press on their forehead to try and kind of compress that artery, and the pain would get better for a few minutes. And then they would release that, and then the artery would start beating even harder, and the pain would come back worse. I hear that all the time. We
Okay.
realize that sometimes those nerves pass through the actual forehead region completely surrounded by bone. And so sometimes we had to chip these few millimeter pieces of bone away to fully release the nerve. So we began to really understand a lot of the nuances and the differences in the baseline anatomy that you saw with
Okay.
these nerves. A lot of other studies came out that demonstrated that there were actual structural differences in the nerves
Mhm.
themselves that predisposed them, I mean, made them more likely to be affected by normal anatomy. So, for example, Baum and Guyeron did a really nice analysis where he looked at the zygomaticotemporal nerves, that's these two nerves here, of patients who were having brow lift surgery, meaning had no
Okay.
history of headaches. They were just looking for an aesthetic improvement. And this is a nerve that is routinely cut when you do that operation. First of all, highlighting the fact that in some cases you can cut nerves. And if you
Mhm.
manage it appropriately, they don't cause problems. But he looked at those nerves and they had a certain kind of appearance that was kind of deemed normal because those patients had no headache symptoms. But when you did the same operation to remove that nerve and cut the nerve in a headache patient, the structure of the nerve itself, even under very high microscopic power called electron microscopy, there were a lot of
Mhm.
abnormal derangements. And so, uh, if you don't have temporal headaches and you have a nerve here, it's very likely right next to a blood vessel that, again, is pounding against it with every heartbeat. But in your case, that's not causing a problem because the structure of that nerve is normal. When the structure of that nerve is abnormal, that same little pounding that we all likely have causes significant pain. And so,
Wow.
again, we had to not only manage the nerve sometimes, but the blood vessels around the nerves.
Okay.
And there were a lot of other articles that started to come out that really vetted from a very practical standpoint that this type of work was beneficial not only to patients in terms of quality of life, because as you can imagine, the
Mhm.
significance, the significant degree of pain that you have is, the volume is turned way down, your quality of life
Mhm.
is better. But there were also a couple of really nice papers demonstrating that it led to a lot less resource utilization. So when patients don't have pain, they don't go to the doctor as often. That means
Mhm.
fewer days off of work. That means less of an
Mhm.
opportunity cost, meaning you get to go to work, you get paid more days, or
Mhm.
you're not using your paid time off to, go to the doctor or go
Yeah.
to the emergency room. Um,
Mhm.
the emergency room, people were going to the emergency room a lot less. That means they were getting
Mhm.
a lot fewer CAT scans and MRIs, which can be very expensive. They were being exposed to less radiation, had a lot less contrast. Because if you show up to the ER with a headache that you think your head is going to explode, they're going to be worried about brain tumor and aneurysm. And so that's a very common
Yeah.
way to look that up. People were using a lot less medication. And I think that that's a very important development because I think that it's certainly a multifactorial problem, but one of the reasons we have a huge opiate crisis in this and many other countries throughout the
Mhm.
development and as well as the first world, so to speak, is because
Mhm.
when people have chronic pain, doctors, well-meaning, will often prescribe pain medication. And it doesn't often work very well for pain that is caused primarily by nerves.
Mhm.
Um, but is something that people are often put on and often for many, many months. And unfortunately, a lot of people get addicted to those pain medications. So I think that
Mhm.
as one example, we were realizing that headache surgery really reduced pain medication usage. And so these sorts of developments in the first 2 decades, what I like to say, and I think what I said in that article was that the first decade was really about kind of a rediscovery and an understanding of the anatomy. And the second decade,
Mhm.
refining the technique. We started to have long-term uh, studies coming out that were saying, look, it wasn't just that at 6 months the patients were happy, but a lot of this symptom relief lasted 5 years or more, and in many
Mhm.
cases that if things are still stable and improve 5 years later, it's considered essentially a permanent result. And we continue to follow these patients. I have people 9, 10 years out that I still occasionally run into and get a chance to interact with, and I'm still very happy.
Mhm.
So yeah, and that will be something hopefully we can discuss in the next installment here. But I think this
Mhm.
setup really sets the stage for the other focus I made in that article was, hey, where are we going from here? What's on the horizon? Which again, I think looks very bright.
Yeah, absolutely. And I want to thank you for bringing up the quality of life factor for these neuralgia patients and these headache patients because it seems so often to be overlooked that meanwhile these patients they're in chronic pain. For so many of
Mhm.
them it's 24/7. They wake up in the morning, they are going to bed in pain. They don't catch a break, right? So they're going to the overall consensus from our members at ONF, so many of them have seen different doctors and they've been told, you know what? No, the pain's all in your head. There's no way that you truly have a headache 24/7. And they are just being dismissed. And it's very important to also look at while you're in chronic pain, you're dealing with these headaches, every single aspect of your life is being affected, right? It's not just the pain, it's your relationships, it's your
Yep.
family, it's your livelihood, whether or not you're able to work, go to school, different things like that. So I
Mhm.
really, really thank you for bringing that up because I mean, even in your paper, you mentioned that migraine is the second leading cause of of long-term disability,
Yeah.
for meaning like days lost for work, days lost of school. So I mean it's incredibly important to look at things in that sense also.
Yeah, I couldn't agree more. I think that study is a really important one to cite. It's actually it's a critical study that I think is put out every 5 years or so, and it's called the Global
Okay.
Burden of Disease, or GBD. And
Okay.
it's really a study, and I'm not sure who coordinates it, but it's an international study looking at basically healthcare systems throughout the world. So we're talking about nation states and their entire
Hmm.
healthcare systems. And what
Hmm.
that study showed, the most recent one, which I think the last one that was published was in 2016. So
Okay.
I think there's one due out. Or maybe there's a slightly more recent one, but the last one I found was in 2016 that listed low back pain, I believe, was the number one cause of something called years lived with disability.
Hmm.
Headaches were, specifically
Yeah.
migraines, were number two.
Right.
And that's just one subtype of chronic headache. Forget cervicogenic headaches or new daily persistent
Hmm.
headache. Many of my patients come in carrying those diagnoses as well. Cluster
Sure.
headaches and the usual tension headaches that we all get. Migraines are just some of the more profound and dramatic examples of it. But yeah, it
Wow.
really highlighted so many of the aspects of life that are diminished when you
Yeah.
have chronic pain. And I think that one of the interesting things perhaps we can get to in more detail
Hmm.
uh, is speaks to exactly what you're saying, because I think that so much of the time um, it comes to define your life in the sense that
Hmm.
it determines what you can do, where you can go, what kind
Hmm.
of medicines you have to carry with you, who
Right.
you can interact with.
Hmm.
So it's not just about what it's like to have pain all the time, which is awful in and of itself,
Right.
uh, but what that does to every facet of your life, as you
Sure.
mentioned. Yeah, yeah, really,
Right.
really important work.
Yeah. And you know what? This seems like a great way to kind of wrap up this portion of our discussion. So, to our viewers, stay tuned because we will be sharing part two of this great discussion where we will kind of learn more about what the future is looking like for occipital neuralgia and headache surgery. And then to you, Dr. Peled, thank you so much for taking the time today to share a little bit about your expertise and your knowledge surrounding ON and these headache surgeries. I know I learned a great deal, and I'm confident that our viewers have as well. But before we go, remind us again the best way to find you if we're interested in learning more about you and your practice.
Thank you. So once again, thank you for the opportunity. Really looking forward to part two. As you said, there's
Absolutely.
a lot of really exciting things that I'm personally excited about. But
Hmm.
in terms of finding me, www.pelledsurgery.com, also Pellet Surgery on Instagram. We try to do a good job. I have a whole blog post page where I really just have addressed a lot of the questions that people have asked me either personally through DMs on Instagram, through Facebook messages, and I'm dating myself here perhaps a little bit, but when I first started, Facebook was the only social media platform out there. But I think it is a very rich source of information that will hopefully answer a lot of people's questions about a lot of different things. And then, of course, we have our office numbers and email addresses that you can contact us through if you go to any one of those resources. So that's a great place to start.
Great. Okay. And then
All right.
just a reminder, if you're interested in learning more about the Occipital Neuralgia Foundation, make sure you check out our website at onfsupport.org. And then again, we are also on social media. Our Instagram is occipital.neuralgia and our Facebook is Occipital Neuralgia Foundation. So thank you again for your time, and I'm so excited for part 2 of this conversation.
Me as well. Thanks, Kayla. Really appreciate it.
Thanks.
Cheers.